Chairperson Howard, Chairperson Stenner, and the members of the Health and Human Services Appropriations Committee. Thank you for the invitation to provide more information about the Heritage Health Adult Program. Chairperson Howard, thank you for meeting with Ryson and me on Friday, April 5th, 2019. I appreciate that you had an agenda and questions about Medicaid expansion ready for us. On Friday afternoon, I received your letter, Chairman Stenner, with questions from the Appropriations Committee. That same afternoon, I met with my team to discuss the questions from both committees. Implementation of the Medicaid expansion is important to the department, and we are committed to making sure it goes smoothly. We are here to support Nebraskans and in their path to wellness. With that in mind, my team and I are thankful for the opportunity to present to you again. We have organized our presentation to share our Medicaid expansion plan going forward in a more straightforward manner. And quite honestly, Chairperson Howard, I took your questions and I tried to organize them in a way that we would be able to expeditiously use the time, but also a good chunk of the time to be able to answer any questions that you may have. And so from your agenda and the questions that you gave me, here's how I organized it. We're going to start off by talking about benefits, administration, community engagement, finance, and cost allocations. You will notice that when Dr. Van Patten comes up, in his remarks, he is going to make reference to the questions that you may have before you and the answer that is associated with that question. So we're trying to be very organized so that you can get a really good breadth of the work that's being done. Throughout today's presentation, my team will attempt to answer all the questions you've provided to us. I want to reiterate something we have previously stated. The documents submitted to the Center for Medicaid and Medicare Services on April 1st, 2019 began the discussion with the federal government about Medicaid expansion in Nebraska. Throughout the upcoming months, we will be negotiating with CMS regarding our plan. In fact, my team has already begun conversations with our partners at CMS, with the last call being on Friday, April 5th, 2019. So we've already begun the process. I am asking you to allow us to remain flexible and agile as we move forward and receive feedback from CMS. Dr. Van Patten will be sharing the technical aspects of Medicaid expansion in a moment, but I wanted to take a little bit of time to share an example with you of a scenario of someone who may be being served under the Heritage Health Adult Program. Imagine Jennifer. Jennifer might be a server who waited on you at lunch today. She might have been a person at the window where you dropped by and got coffee from the coffee shop this afternoon. Or she might be a caretaker for a family member. She is an adult who is the new expansion population, meaning she's an able-bodied person between the ages of 19 and 64 years old and has an income of approximately $16,000 per year or less. Jennifer is not pregnant and has no dependent children. When Jennifer enrolls into the Heritage Health Adult Program, she'll be enrolled in the basic coverage. In 6 months, she can move to prime coverage if she engages in care and case management and makes an appointment with a primary care provider. In second year of her eligibility, if Jennifer wants to continue with prime coverage, she'll need to participate in community engagement requirements, which are engaging in job-seeking activities, caring for a relative, attending a post-secondary school or apprenticeship, or volunteering for a public charity for at least 80 hours per month. If she chooses not to, Jennifer will return to basic coverage for the next 6 months until the next eligibility check-in, at which time we will do verifications, which includes residence and income. As long as Jennifer continues to meet the eligibility requirements, she will always have basic coverage in the Heritage Health Adult Program. Again, Jennifer can be anyone you know. Jennifer represents a number of people that I've met since I've been here in Nebraska, and I'm sure that there are constituents in your district that represents Jennifer. At the conclusion of my remarks, Lisa Taylor Jones and Karen Vincent will be distributing to each of you a binder of information that will further clarify the design and implementation of Medicaid expansion. In that binder, you will find planning and reference documents that have guided us throughout this process. Dr. Van Patten will be presenting again on the technical aspects of expansion. When he is finished, Jeremy Brunson, Medicaid Deputy Director of Finance and Program Integrity, will address the specific questions from the Health and Human Services Committee and Appropriations Committee around finance and cost analysis. We have provided a PowerPoint for your review in the front of your binder that you're going to be receiving shortly, so that you can follow along with their presentations. Again, I want to thank you for your attention this afternoon. We are prepared to be able to give you good information, and we are committed to a successful implementation of the Heritage Health Adult Program to serve our fellow Nebraskans. With that, I'm going to ask Dr. Van Patten to join me here at the table.
Your table 10. Thank you. Thank you.
Okay, great.
Does everybody have a binder? Are you ready?
I'm ready.
All right, Sherry, hit the light.
Good afternoon, Chairwoman Howard, Chairman Stenner, members of the Health and Human Services and Appropriations Committees. My name is Dr. Matthew Van Patten, and I am the Director of the Division of Medicaid and Long-Term Care within the Department of Health and Human Services. I am joined today by my Deputy Directors, Rocky Thompson, Heather Lashinsky, Jeremy Brunson, Dr. Laura Peterson, Karen Hain, and our legal counsel, Nate Watson. As CEO Smith indicated, we are providing you with a packet containing the following exhibits. You should have the table of contents on the front. Exhibit 1, Medicaid Expansion Briefing Slideshow. Exhibit 2, Nebraska Secretary of State Petition Sponsor Sworn Statement Initiative 427. Exhibit 3, State Plan Amendments with a SPA, Benefit SPA, the Finance SPA, and the Eligibility SPA. Exhibit 4, Heritage Health Adult Program Implementation Plan Timeline. Exhibit 5, Articles from Other States Expansion Experiences. Exhibit 6, Various Federal Medicaid Law. Exhibit 7, Current Medicaid Benefit Packages by Eligibility Category. Exhibit 8, Heritage Health Adult Program, Section 11-15 Waiver Concept Paper. Exhibit 9, Introduction to Medicaid Care Management Best Practices. Exhibit 10, State Medicaid Director, SMD 18-002, Opportunities to Promote Work and Community Engagement Among Medicaid Beneficiaries. Exhibit 11, State Differences in the Application of Medical Frailty under the Affordable Care Act 2017 Update. Exhibit 12, Heritage Health Adult Program Eligibility and Enrollment Process Chart. Exhibit 13, Heritage Health Adult Program Prime Basic Scenarios. Exhibit 14, Analysis Fiscal Impact of Initiative 427. And Exhibit 15, Press Release, Nebraska Medicaid Director Dr. Matthew Van Patten comments on Centene/WellCare merger announcement. We are providing these documents to let you know in detail about our planning efforts, as well as to provide reference materials that have shaped our thinking in designing the Heritage Health Adult Program. A copy of our slides is provided as Exhibit 1 in your packet. In my remarks, I will address most of the written questions we have received from Chairwoman Howard, and then Deputy Director Brunson will address Chairwoman Howard's cost questions, as well as written questions we have received from Chairman Stenner. Pursuant to the initiative, a copy of which is attached as Exhibit 2 in your packet, the Heritage Health Adult Program will cover all able-bodied adults between the ages of 19 and 64 who meet the various requirements, including the adult expansion and caretaker relative populations. This program will use our existing managed care health plans to provide medically necessary care to people who cannot afford it and promote wellness and life success. In response to administration question number 5, it is important to note that any legislative action that would significantly affect Medicaid, including the ability to use managed care, would inevitably delay our ability to begin benefits on October 1st, 2020. We have successfully fulfilled the first step in the expansion process, the filing of the state plan amendments with the federal government on April 1st. This was the one and only deadline in the initiative. A copy of the submitted state plan amendments is provided as Exhibit 3 in your packet. Benefits begin on October 1st, 2020. Sign-ups start on August 1st, 2020. We understand that many people would like these benefits to begin sooner. However, our priority is making sure the necessary preparations have been made, the services are available, and the people know how to access care. We are taking the time needed to do this right. In the packet at Exhibit 4, you will notice a timeline of the work that needs to be done. Furthermore, the experience of other states demonstrates the wisdom of taking the time necessary to do this right. Anything less would be letting down the people we serve and the taxpayers who pay for it. In your packets at Exhibit 5, you will also notice news articles that demonstrate this reality. This is the second slide if you're following. There are several different ways to become eligible for Medicaid. Many people understandably think that Medicaid currently provides the same package of benefits to everyone enrolled, but it does not. Pursuant to federal law, for example, sections 1902, 1915, 1920, and 1920A of the Social Security Act, copies of which are provided as Exhibit 6 in the packet, Medicaid covers a variety of persons with different needs. For example, children receive additional and different services than adults. Persons with disabilities have different services than others who are not disabled. Pregnant women have services designed for their specific needs. Residents in nursing homes receive services tailored to their circumstances. In your packet at Exhibit 7, we have provided you a chart comparing the benefits of those persons currently eligible. The Heritage Health Adult Program is designed for able-bodied adults on Medicaid. In short, all persons similarly situated are treated similarly, in line with federal law and the initiative. Third slide. In response to benefits questions number 7 and administration question number 3, to design a program that best fits the needs of Nebraska, we intend to submit a Section 1115 Medicaid demonstration waiver to the federal government. This process began when we submitted a concept paper on April 1st. The concept paper, which is Exhibit 8 in your packet, covers a number of proposals that not only provide health care coverage, but also provide an innovative route to wellness and life success. The 1115 process involves negotiations with the federal government. Federal law requires at least 2 public hearings as a part of this process. We will hold at least 4 on dates and at locations to be determined, including at least 1 public hearing in each congressional district. 4th slide. In response to benefits question number 1, Heritage Health Adult Program participants will receive basic coverage that is comparable to the type of health insurance many Nebraskans receive through employment. The precise package of services will be defined after negotiations with the federal government, though it will be similar to the Blue Cross Blue Shield Pride plan. A point-by-point comparison of Medicaid state plan services and this commercial insurance product is included. Reevaluation. It's the same workforce. I already have to hire them to accommodate this expansion population to begin with. And they're added to our existing workforce who are already functioning in this area. No way around it, Senator. It has to occur.
I would just push back and say that anytime we add layers of requirements and regulatory requirements, it comes with a fiscal note. And so my concern is we are creating a program that is more costly to the state than by simply utilizing the current structure we already have with Medicaid and more simply expanding that out.
Your statement's noted. Thank you.
And actually, that's a really good point, Senator Wisher. Director, perhaps we should talk about cost. Who's your next speaker?
That's Deputy Director Brunson.
Great. Don't forget your name tag. Good afternoon.
Good afternoon. I'm Jeremy Brunson, Deputy Director of Finance and Program Integrity for Medicaid and Long-Term Care. Good afternoon, Chairwoman Howard and Chairman Stinner, and members of the Health and Human Services and Appropriations Committees. Excuse me. I appreciate the opportunity to respond to the budget and cost questions on behalf of the Division of Medicaid and Long-Term Care. For ease of presentation and transparency in responding to your questions, I'm going to respond to them separately as the questions were presented from a different perspective. I'd like to begin by addressing the questions we received related to costs from Senator Howard and the Health and Human Services Committee. These topics are on slide 9 for your reference. To answer the first question received from Chairwoman Howard, the objective of the 1115 waiver is not cost savings. The primary objective is intended to meet people where they are to provide pathways for wellness and life success. It is important to note that part of the 1115 waiver demonstration is a financial demonstration that requires that the waiver pass a budget neutrality test. While there may be potential savings in aid costs as a result of administering the Heritage Health Adult Benefit Package, any potential savings or cost differentials have not been determined, as key components of the benefit plan need to be reviewed and approved by CMS as part of the 1115 demonstration waiver process. Regarding question 2, additional administrative costs will be expected. To operate under the structure proposed for the 1115 waiver, IT costs and staffing, such as for the 6-month redeterminations, are the primary drivers. While there is an investment on the front end for these administrative costs, this investment positions MLTC to mitigate long-term risk for program integrity issues identified from other states' expansion experiences, where states have incurred large federal disallowances for federal share payments made to ineligible beneficiaries. I would reference the articles included in Exhibit 5. The investment also allows us to ensure that we provide a high-quality experience with the Heritage Health Adult Program for beneficiaries and providers, and to maximize on the value of the buy we already make with the managed care organizations for our beneficiaries. To that end, we do not anticipate increasing capitation payments to the MCOs to administer the program. Currently, the MCOs receive an administrative load of around 10% of their per member per month medical costs. This administrative load compensates the MCO for the value they bring as a managed care organization for things such as care and case management, utilization management, claims processing, providing value adds, provider and community engagement activities, and program integrity activities. Furthermore, we have not quantified any savings anticipated as a result of community engagement requirements, as this is not the intent of the waiver. In response to question 3, currently Nebraska is one of 47 states covering adult dental services in some form, most of which offer the benefit in a limited capacity for adults. I would like to note that Nebraska Medicaid reduced the adult dental benefit limit from $1,000 to $750 per person per state fiscal year, beginning in state fiscal year 18. Emerging data does not show any material increase in emergency department visits for dental issues from this change, despite an average reduction of utilization per 1,000 beneficiaries for adults of around 15%. More detailed analysis will be a part of the budget neutrality financial projections for the 1115 waiver demonstration. Furthermore, we would not anticipate an impact to providers for the services not included in the basic coverage. On question 4, Medicaid supports consumer choice as a part of the Heritage Health Managed Care Program. We issued a press release regarding the news of Centene's potential acquisition of WellCare and have communicated the department's expectation that the health plans honor the terms of the current contract period, which ends effective December 31st, 2021. This press release is provided as Exhibit 15. Regarding question 5, the MCOs have not expressed concerns about the Heritage Health Adult Program. MLTC has engaged them as stakeholders to date for feedback and will continue to engage them as we work on the 1115 waiver. Finally, to respond to Chairwoman Howard's 6th question, MLTC will amend the contracts to include the enrollment of the Medicaid expansion population on or around April through June 2020. This is noted in our timeline, Exhibit 4 in your binder. Medicaid does not negotiate terms and conditions or rates for our MCO contracts. At this point, I would like to transition to slide 10 and address the questions we received related to the budget from Senator Stinner and the Appropriations Committee. Medicaid continues to update the expansion cost estimates for each state fiscal year of the upcoming biennium. We do not agree that a prorated approach of 9 months relative to the start date being 10/1 as opposed to 1/1 is appropriate. We are in agreement that there should be no reductions or offsets to aid for Program 348 for women with cancer, Program 347 for state disability, and Program 038 for behavioral health in state fiscal year 20. We are providing updates for the offsets amounts for these programs for anticipated cost offsets in state fiscal year 21. The program is anticipating a significantly higher ramp up of members due to the additional time to the implementation plan, heightened public awareness, and the early beneficiary application period. We're assuming a full ramp up as of October 2020, and our offsets assume 9 months of offsets versus 12 in state fiscal year 21. Similarly, for Medicaid expansion aid costs, the assumption of a prorated reduction is not appropriate, given that we've estimated a full ramp up on October 1, 2020, as noted above. We are providing an updated aid estimate, assuming that full ramp up for 9 months of state fiscal year 21. Medicaid is not estimating any aid expenditures for state fiscal year 20. We would also caution that while we've done significant research, there still remains some uncertainty as to what to expect for counts of individuals that currently have insurance availability that may become eligible for Medicaid. Nearly every state that has implemented expansion has seen higher enrollment than what was initially estimated, as documented in articles in Exhibit 5. Specifically, the article titled Medicaid Expansion Enrollment is on Track to Surpass Projections. We'll also be providing an updated estimate for the administrative costs for the Medicaid expansion implementation and operations. Most notably, we do anticipate increased IT-related costs and additional staff to implement the Medicaid expansion plan as submitted. We are asking to move some preliminary aid appropriations to administrative appropriations to implement the program. This is a thoughtful and purposeful plan to implement a program that is aimed at providing a high-quality experience for beneficiaries and providers, as well as to increase our program integrity and data and analytics infrastructure to mitigate significant financial risks that have been experienced by other states that have implemented without that proper infrastructure in place. While we have researched and planned extensively for this implementation, we continue to assess and learn as we work with internal and external partners. As such, we respectfully ask that the Appropriations Committee support the total amount the Governor has recommended to implement Medicaid expansion for the 2-year biennium. This will allow the department to have the resources necessary to implement successfully without delay. Any unexpended appropriations that may accrue during the upcoming biennium should be preserved to address the remaining and any new uncertainties related to Medicaid expansion and the potential growth of enrollment for the following 2021 through 2023 biennium. We would like to reiterate that while we have worked hard to prepare a sound plan, there are several items that have surfaced as new learnings that are not fully incorporated as documented expenses in our estimates. We do not have sufficient information or data to document the request. The items include things such as the fact that nearly every state that has expanded has experienced more eligible persons in the expansion population than the original state or national estimates projected. Also, that the program integrity issues included significant audit findings that carried millions of dollars in disallowances for benefits paid to persons that should not have been eligible. For increased infrastructure to support the data and analytics platforms and processes to prove our outcomes and experiences for members and providers, and to increase our infrastructure for formal processes and resources to perform provider rate studies to ensure proper payment and access. Thank you again for the opportunity to speak to the questions provided on cost and budget from both committees. I would now like to invite the Medicaid Director, Dr. Matthew Van Patten, to return for final remarks before taking questions.
Thank you.
Excuse me.
Thank you, Heather.
Senators, I now invite my team to stand and join me here to answer any additional questions. I would also like to let the public know these documents will be made available on the expansion website. I would be remiss in not acknowledging this team's work and professional competency. I would also like to thank this group of public servants for their work and commitment to building and implementing the Heritage Health Adult Program. This concludes our remarks. We'll take your questions.
Do you want additional chairs?
We're happy to stand, Senator.
Unfortunately, actually, it's a hard time for the microphone, and then people in the back can't hear you.
Why don't we, if somebody is
Maybe
answering,
we'll
why don't we
just
step
tag
forward?
in. How does that sound? You actually will want to leave the chair there because they can't hear you if you're standing.
Okay.
All right, are there questions? Senator Bowles?
I have several. I'll maybe start with a couple and then let other members ask questions as well. Let me start here and ask, your slide 10 fiscal analysis assumes average monthly enrollees of 88,602. Previous projections and fiscal analysis that we have seen, and specifically I've spent time with some analysis that our legislative fiscal office has done, assumes a ramp up. The one version of an assessment that we've seen assumed 53,000 in the first year. And so in terms of trying to understand what the implications on the aid budget would be, can you help me understand why is it we would assume kind of a 0 to 60 enrollment process?
Sure. So thank you for your question, Senator Bowles. And I think to reiterate, in our original projection in September from the department, we had the same ramp-up period. Given that we have more time, we're engaging the public more in this plan, given that we have the early enrollment period, and given, frankly, the information that we've been able to gather since the fall around experiences in other states with applications coming in at a higher rate up front than those states had planned for, we felt it would be the best course of action to assume full ramp up, which the 88,000 was essentially the full ramp up, which would have been year 3 of state fiscal year 3, 2.5 years in, just because we've seen the experience in other states show the applications coming in at a much higher rate than they anticipated.
It might be helpful to share with the Appropriations Committee that first year of ramp up information from other states, because I think that because we have seen other projections that show a slower ramp up, we probably also need to get that verification that that's a fair assumption to be making from the beginning. I think the thing that I'm having the hardest time really understanding and making a judicious decision about is your assumption that you won't need any changes in the aid budget. I don't mean to oversimplify. This is obviously a very complicated set of circumstances, but it's very hard for me to understand why you would have a 9-month change in eligibility and no change in what you expect to expend in aid.
So there actually is a change in, maybe if I get my book, I can walk through it with you, because that chart is just to help follow along. The aid is reducing, so we're not anticipating any aid request in state fiscal year 20 for obvious reasons. We're not paying any benefits for beneficiaries or for members at that point in time. And in state fiscal year 21, we did provide what we anticipated to be the net aid request, which is full ramp up, but at 9 months versus 12. So it is a little bit less, I believe, than the original ask. I'd have to go back and pull all the spreadsheets. But in addition, we put in the contingency aid, just for the fact that we could have an overrun. We've seen experience in other states where they've had program integrity findings. And so, for example, I think where I would want to go with that is the expansion population audits that have been done have revealed some troubling costs for states. So what would happen would be if we pay, if we were to ever have a situation where there is an issue where we pay for benefits where a member is not eligible for any given period, while we've already paid the 10% state share up front, say that's $1 million for however many people, I'm just using round numbers for easy math. If we were to have a finding, the finding would be for the full 10 million, and we would have to pay back the 9 million, the federal share. So there's a lot of risk in that, so there's a lot of unknowns with the overrun. We're just trying to make sure that we have the money that we think we need to cover the biennium. It's very possible that we would have funds that are accrued, not spent, as I mentioned in my remarks, but given the experience that we've seen in other states with the overruns, I think it would be, we're recommending that we leave that there for the Medicaid expansion population.
How much of a cushion do you, I mean, I appreciate that you want to mitigate risk. That makes sense to me. How much of a cushion is fair to expect? 10%, 20%? I mean, what you're saying is that we should prepare for the contingency that you enroll non-eligible members. Is a reasonable expectation that you get 9 out of 10 right, 8 out of 10 right? I'm not trying to be hard on you. I'm trying to understand.
I think that's I can't make a definitive statement as to what % should be in the contingency. That would just be making something without any facts in front of you, and I don't want to do that. So we can continue to go back and refine. Like I said, this is a process. It's going to be an ongoing process, and I appreciate the position you're in where you have limited time to put a budget together, and we're here to work with you on that as collaboratively as possible.
I have 2 more questions, if I may have the patience of the committee. The first is, I just want to make sure I'm clear. The governor's budget recommendation is in front of me, and I'm looking at the aid in 2021 general funds, Medicaid services, and the allocation in my governor's preliminary budget recommendation is 49.2 million, right? That was the request in the governor's budget recommendation.
In total, before the offsets, is that correct?
Right.
Okay.
Aid, Medicaid services, general funds, 2021. Okay, so I'm crosswalking that with what I see, and maybe I'm just not understanding your chart, but I'm crosswalking that with net aid state funds, 21 of 49.8. Can you help me understand why the aid would be the same for the second year if we have a 9-month eligibility and enrollment difference?
So I'm not sure I followed exactly where you are. So I see where you're talking about on the net aid. What I can talk to is the fact that in state fiscal year 20, there should be a stark difference. There should be $0 versus the roughly $19 million that were in there.
Right.
For state fiscal year 21, let me pull out my chart. I apologize. It'd be easier for me to talk to this way.
You've got
Yeah, so in state fiscal year 21, the gross aid that we were projecting based on around 71,000 average monthly enrollees in state funds was around 49.2. The total gross aid that we're projecting now was, what, 46.1 in state fiscal year 21, not the net aid, the gross aid, the kind of the apples to apples comparison. And the difference is we would assume full ramp up to 88,000, but 9 months versus 12. So that's how it plays out. It's assuming the same per member per month cost.
Okay. I'm still not sure I'm following you, but I'm not going to take any more of the committee's time. I do want to ask one last question, which is when we had the governor's preliminary recommendations, there wasn't any specific recommendation or any note or comment yet about the medically fragile population. Do you have any estimates of additional expenditures that would be associated with what you expect to come in under the medically fragile population?
So nothing at this point, because those folks would be in that 1115 waiver demonstration. So right now, that's part of the process of putting together kind of the budget neutrality test. So it's very complicated. A lot of it's going to depend on what exactly that definition says. There'll be higher cost, more than likely, because there'll be more like a disabled type benefit package or need for that member. So I don't have any detailed information I can provide from a financial perspective to you today.
Thanks for your patience.
Other questions? Senator Hilkeman?
Yeah, I have a question regarding the benefits. You have your basic benefit, and then you have your prime benefit. And with the prime benefits here, it says it adds dental services to it. Are you including all optional services in basic coverage?
All optional services in basic coverage?
That's Medicaid optional services in basic coverage.
No. So go ahead.
Hi, Senator. The basic benefit package and the prime benefit packages are not, they're not established yet because we're working on that with CMS. We're not anticipating that all optional benefits will be covered in the basic benefit package.
You're saying that you will not cover all optional services?
We're not anticipating that all optional services will be covered. It's going to be comparable to commercial insurance.
Well, commercial insurance covers all the optional services.
They cover at different degrees.
I would challenge you in this to find one state that cut out optional services in Medicaid that ever didn't go back to finding it was more costly to cut out the optional services in Medicaid than to continue those optional services.
And we are working on that benefit package, and we will have at least 4 public hearings about that. So we are seeking public input into the
So
final
you've
benefit
not
package.
made any definitive decision yet whether you're going to, because you specifically mentioned dental services coming in your prime, which is also an optional service in basic in Medicaid.
That's correct. But we haven't made any final decisions about the exact benefit packages.
And it would be, why would you even, I guess I have a hard time understanding why you're even considering that. Consider who's going to be providing the dental services in the first 6 months when people are all on basic services.
Who will be providing? Is that
That's
where-
correct. In other words, if you're adding dental benefits after when they qualify for prime, who's taking care of them during the basic period and they're on basic coverage?
We anticipate these will be the newly eligible population, so they will be new to the Medicaid program. And so we will work with our case and care
But it's
managers.
a 6-month period of time. Are you saying for 6-month period of time they're not going to need to have any dental care?
We anticipate that most of them will go into the prime package where dental care will be available.
I think, Senator, that's also the point of active care and case management. And I want to continue to reiterate what this means.
Director, could you sit
My
down?
apologies, yes. I want to continue to reiterate what this means. This is using our managed care organizations, getting from basic to prime within that first 6 months to the reevaluation of eligibility. All you have to do is engage with the MCO. That's as simple as taking a call and having a phone conversation about where you are and finding out what you need and then helping you track to that provider. So there's no lift here. This is what our managed care organizations already do when they onboard someone into the program. They already have this initial reach. So again, moving from basic to prime, we've made a process that makes that a very easy activity for the beneficiary. At the same time, it pushes the value of the buy the state's already making to the forefront of what we get from those MCOs as they engage with this new population. Again, so we can help them figure out, where do you need to be? Do you need dental services? Do you need vision? You know, you've got to get to the primary care exchange first. That's your baseline history and physical. That tells the picture of what we're going to be managing to. And again, all you have to do is have that initial conversation with the caring case manager. You've hit the switch. You're done. And then you got to get in to go see the primary care provider. And then from there, we know how to help you care navigate. That's the intent.
So what you're saying is that for the first 6 months, that as long as they've at least checked in with their primary care physician, if they end up having an abscess tooth or something of that sort, that they can go to a dentist to get it taken care of.
Well, again, as Deputy Director Thompson reiterated, we're at the beginning of a process. We have to negotiate our package with CMS. First thing to remember. Second thing to remember is we're going to have public hearings where we solicit this feedback from the public. We want to hear how they want to approach based on what we've put forward. And that's the intent of the 1115 waiver. It gives us those opportunities to engage and hear those feedback and then help us take that back and negotiate what we end up completing a package with from CMS. Would anybody else like to add?
Senator Arch?
Question, and maybe Dr. Van Patten, you'd be the best one to answer this. I don't know if you could let anybody else answer it as well. What I see you attempting to do here is patient engagement, personal responsibility, becoming active in their care, and taking a personal interest in that care. I think across healthcare, that is generally accepted as how we are moving in healthcare. So because outcomes are anticipated to be better with that for the patient. I guess my question is the follow-up then. So this is a demonstration waiver. This is something that we are going to make an attempt to do. Your outcomes data, your analysis of results, we will be very interested in seeing, does it work? You know, does the engagement of the patient, does the incentives actually improve care, quality of care, which is what we want for the state to be investing in this, we want to see a healthier population in the state of Nebraska. What are your plans for outcomes data?
Absolutely. So I think you're really getting into, frankly, why I took the job to begin with, because this is where I see the real benefit of public benefit portfolios like Medicaid really meeting the individual and serving their needs where they are. And also, I think from the state standpoint, and I know many of you have heard me say the quadruple aim, is you're assessing the experience of care in quality and satisfaction. That's both the cost and the consequences. Same thing for the provider. Again, impacting the health of populations on the whole, and are we reducing the per capita cost of health care? The constructs of that, the latter two components in particular, get into the discipline that you and I know to be population health. That said, you've also heard me say we've been building with Deloitte a new data management and analytics tool. You've also heard me reiterate our connectivity to NEHI and onboarding new data such as the PDMP, where we can begin to bridge the gap between encounter data that comes in off of a claim, diagnosis data, and RX. So you're moving from diagnosis to RX, and you can begin to paint that picture of broader connectivity. That's the enterprise that Dr. Laura Peterson, who we onboarded in September, has been working to build, starting first with the establishment of the data management and analytics platform. And I would invite Dr. Peterson to add any comments to that as well, and come join me here at the table.
So one of the articles that we asked to be included is Exhibit 9. You'll see this article was actually published by our federal partners at the Center for Healthcare Strategies in 2011. Much to your point, Senator Arch, this is an ongoing initiative in healthcare. We know that providing care in siloed manner only facilitates a more disruptive healthcare experience for our beneficiaries. We also know that individuals with increased social determinants of health, such as a Medicaid beneficiary, providing care in that siloed manner can be more dangerous to their healthcare outcomes than any other patient that hospital systems may experience. It's our responsibility at Medicaid to ensure that we provide an infrastructure that's safe, it's responsible, and accountable. The data management and analytics tool that we're building with Deloitte, but more importantly, whether we pull this from our InFocus using interoperability with NEHI and the PDMP, we provide a value back to ourselves and to the taxpayers in Nebraska by understanding what is the offset in cost and quality through care management. If you have the opportunity to read the article from 2011, there's 5 different state demonstration projects documented there where they consistently prove over and over again the value of engaging patients in a manner similar to what we're requesting to do in the 1115 waiver. It's also not just to reduce costs through unnecessary duplication of services, such as at a local health system I worked at here in Nebraska. We had an unfortunate beneficiary who went into the ED with migraine pain multiple times and received multiple MRIs. There's now enough data to suggest the difficulties with that multiple MRI may have health consequences to beneficiaries. Those are individuals often who cannot necessarily bring their entire portfolio of care with them. They may not be savvy enough from a patient education or health literacy perspective to be able to communicate all the disparate needs they have. So we're taking that responsibility to try to put an infrastructure in place up front. The best way to do that, because many people who have mistrust of the federal system, of state bureaucracy, and Medicaid in general, may not actively engage in care management without finding a way to incentivize their ability to engage and then use patient engagement techniques after that first visit to help them find a better healthcare experience throughout the silos of care that exist in healthcare today. It's not that anyone provides bad care, it's just a byproduct of how health systems are established. So to your point, we have a number of what we're calling key performance indicators. If you are able to look at the roadmap, the Gantt chart that's established, I believe, in Exhibit 4, You'll see on the very bottom, which is one of my tracks, implementation metrics under track 9, post-implementation metrics above that. Implementation metrics are what we're holding ourselves accountable to for the successful implementation of this program. I've been through several implementations from the federal system through local health systems and now as part of state government. Implementing a program is never the problem. It's doing it successfully and accountably to your stakeholders is always the difficulty. And I'm asking for us to have key performance indicators and metrics that we report back on a regular basis without being asked. Post-implementation metrics will tell you the success of the program. Did we reduce cost? Did we improve quality? And do we have better engagement strategies? We've had a lot of conversation about dental. If you look at the research nationally, many patients in these particular groups are not using appropriate preventative dental services. Providing appropriate preventative dental services doesn't negate emergency dental care, unfortunately, because we haven't provided the skills to bridge the gap between using disparate emergent care until it is an urgent condition that's painful and their ability to do it proactively. And that's what we have to be able to incentivize the engagement in care management.
Senator Stinner?
I got to go back to my friend here.
Can I add one more comment to Dr. Peterson and then take your question, Senator?
Absolutely.
I'm not the expert on this. My counterpart Heather Lashinsky is, but also I think it's important to note, in addition to the KPIs we develop with Dr. Peterson, there are submitting the waiver, getting the waiver approved for an 1115. It's not, the demonstration doesn't stop when you start. That's really the starting line. You know, there's follow-up data submissions and proof of concept work that happens as part of that waiver.
There's a research and evaluation component of the demonstration waiver that CMS, through our terms and conditions, CMS will also define what outcomes they want us to report back to them, and will incorporate the KPIs and their performance metrics in our design and evaluation process. And then we do have to report to CMS, and all of that's publicly available. To help Jeremy finish.
Yes, thank you.
So I'm just looking at the same page on Appropriations Committee, your ask. I'm going to treat this like your ask on as it relates to the Appropriations Committee. So you wiped out all the dollars that you were asking for in 20, which I believe was $12 or $13 million. That's gone. But you did add a contingency aid line of $9,672 plus a contingency of the total for the 2 years for administration is 1.5. Okay. That, in my estimation, is a cushion, but that's my interpretation. 88,608 people are used in your analysis. Is that on day one? They show up on day one?
That's correct. So when I referenced full ramp up as of October 2020, that's exactly what I was referencing, was everyone's on board.
Because you have a 2-month period that you're taking applications and processing.
And those individuals that apply during the month of October would be eligible back to the first of the month. So it's really 3 full months of processing applications.
But this is a simple math problem for me, okay? So I'll agree with you on all of those things, and I'll take a look at your request for contingencies, and we'll do the best we can. But I'm going to say this, we used the same amount of dollars that was in the request, the governor's request for 2021. We used the same amount of dollars you're asking for, but the length of time isn't 12 months, it's 9 months. So one would say, okay, I'll do the math and divide 88,000 participants and do a monthly, and now it's times 9, and I got 34 million, or a difference of about $12 million that should be saved.
So
we're got a contingency of 9 plus $1.5 million, plus you're asking me to save another 12 as a buffer. Is that what you're saying?
I would say that the original submitted state fiscal year 21 number wasn't 88,602. That still had some ramp-in period. That number was around 70,880.
You know, I could go back and use those numbers as well and use a ramp up, which would lower my number further that you're asking, the difference of the numbers, but I'm not going to. I'm just going to assume all the things that you assume, but I'm going to point out that you're taking a 12-month ask versus a 9-month ask. And the difference is about $12 million, plus we're going to give you $9,600 in contingency, or $9,600,000 in contingencies and $1.5 million for administration. And I guess we as a committee have to look at that and say, is that extraordinary? Can we do that? And you're saying because of experiences, we need to have that as a cushion. I think that's what you were saying to me.
Thank you, Senator. So I think, just to clarify, yes, so what we're asking for is us to follow the governor's budget recommendation in terms of total funds for the biennium. We are asking to move some of those dollars to admin, which we've talked through. And you are correct that because we have a full ramp in 2021 for 9 months based on $88,000 per month, that number is more than in state fiscal year 21's original ask because it was based on 12 months of 70,000. So there's a difference there because of the count of people, which does drive the cost. You're correct.
Okay. And I was just adding that all up, and it's about $22–23 million of cushion that you'd like to have. So that's something our committee will have to discuss. We'll work with you, though, to try to figure out what the right answer is. Appropriations dollars are awful precious right now.
I can appreciate the position you're in, and we would just reiterate, you know, we've seen a lot of experience, and we want to make sure that we have the dollars to pay for the benefits for these new persons that are coming on.
I truly get that, and I respect that, and I think you guys have done a marvelous job putting this together, so thank you.
Thank you.
Senator Hansen?
Yes, thank you, Chairwoman Howard. I'm just happy I understood that math problem you guys just threw out there. So. I actually worked through all that in my head. So that was good. I kind of want to echo a little bit what Senator Arch mentioned, that I do appreciate the fact that you guys are trying to take a little more patient-centered approach, a little bit more patient responsibility and accountability, and I hate to use the term monitoring, but making sure that our money is being well spent. And so I think I just maybe had a couple questions on maybe some definitive terms first. When you say job-seeking activities, what does that mean?
So that would be engage. My apologies. That would be engagement with what I would refer to as a workforce investment board, but through the Department of Labor. So you're actually engaged with an enterprise that's part of the state array that's maybe helping an individual find a new job if they're currently out of employment. Or they're maybe looking to gain job skills, but they don't know where to start. They don't know how to make that point of connectivity back to a community college or a university. Or maybe they're working part-time and they're going to school. Again, I think this is, again, pushing that patient-centered care and case management, meeting that individual where they are in their life circumstances, finding out where they are today, where they want to be, what their resources are around them that's maybe inhibiting their ability to move forward. And so, again, that's pulling all those existing governmental services components back together and using it, for example, the job connectivity back to the Department of Labor. And Deputy Director Karen Hang engages with this population on the enrollment and eligibility side, and we already have some connectivity with the Department of Labor today, and I'd like to invite Deputy Director Hang to elaborate on that if she would.
So right now, the eligibility staff works not only with the Medicaid program, but we also have the Aid to Dependent Children program, which does have a work requirement tied to it. And through that program, we have a contract right now for Employment First services that's with ResCare. And so some of this population has the ability to also work with ResCare, and they help with job-seeking activities, job coaching, meeting the person where they're at and what they'd like to do for a career, where we need to go to find a job, and maybe there's a barrier that's in the road, like childcare or something that we can resolve that will help them get on a path to self-sufficiency. We also started a program called SNAP Next Step. And in this program, it's a voluntary program that's attached to our supplemental nutrition assistance program, which assists people in finding that have a job already and trying to go down the next step in the career path. And we've had several people find successful. We've been doing it now almost 3 years. And in that time, we've had successes where people have, on an average, increased their income $10,000 a year by working with us to maybe it's attend a job training thing, a trade school to advance your skills. Maybe it's just let's tweak your resume and you could be at Walmart as in charge of a section by becoming a supervisor or moving that next step because we helped you with your resume and some interviewing preparation. So we've had a lot of success with that program, and it's open to the same people that will be in the adult population for Heritage Health.
Okay, can I follow up with that?
Sure.
When you say caring for a relative, what's the definition of relative?
Yes, Senator. There's a federal definition for a relative. So it's an immediate relative, so a parent, a grandparent, a sibling, a child.
I figured, I just want to make sure. And have we ever considered, because I like the idea that we're also trying to take almost sort of a wellness approach, looking out for the wellness of the patient as well, by seeing a primary care physician once a year. We're including dental, vision, stuff like that. Have we ever considered if the patient is smoking, will there be any repercussions for Medicaid?
Senator, there was consideration of that early on. I think that's something that we can continue to consider as based upon the negotiations of 1115 and the public input. If you have any ideas of good ways to track that and good strategies, but we do have smoking cessation currently in our state plan for services.
We're helping get the patient off of smoking, or
That's correct.
We're looking for return on investment. And just maybe a quick question, sorry. I kind of want to play off a little bit what Senator Wisher said as well, but maybe just kind of flip it a little bit, because she talked about some of the maybe burdensome regulatory requirements for enrollees or participants, and maybe that might cost the state some more money in the long term. Do you see how that can maybe save the state money in the long term?
Senator, I think the best person to answer that would be Deputy Director Brunson to talk about the different audit findings.
Physical services. I'm going to see if I can go through all of you here, but I have it over.
Thank you, Senator. So I think I addressed this to a certain degree earlier, and we've been researching and continue to read and try to learn from implementations in other states. I think the fair thing to say is this is a really complicated program to implement, no matter how you implement it, and no state has done it perfectly. And we hope to do it as well as possible, but we want to make sure that we put practices in place in terms of processes and people and quality checks that we could try to prevent as much of that risk as possible. So we see it as an investment on the front end to mitigate long-term risk, because the risk to us isn't what we invested, it's times 9. It's the federal share. So there's a lot of risk if we were to have a misstep, and that's what we're really trying to focus on that side. And it was, I'll be honest, I don't think that was something that I personally was focusing on initially, and then we received a call from Director Verma, or Administrator Verma, and she underscored, you need to look into this, you need to have a plan, this needs to be a pillar of what you're doing. And so, as Dr. Van Patten relayed that message back to us, we made sure that we started to take a closer look at the experiences in other states. And it's not a discredit to other states. This is complicated. We just want to try to do what we can to do it as well as possible.
Okay, just one more quick personal question. I don't mean to take anyone's time.
Nope,
This might
actually, sorry, Senator Hansen, we actually have to keep going.
Nope, go for it, that's fine. I'm done.
Before Senator Vargas, I just want to be really clear. Do we have to do the 1115 waiver? Is that required by any statute or required by 427?
Take that, and then folks can fill in.
And then we'll go Senator Vargas, Senator, and then we'll come back over here.
This is our choice to do it this way, based on looking at, again, what are our strengths as a state as it stands today. 98% of our beneficiaries are currently enrolled in managed care. And that infrastructure is something the state's already paying for. Claims processing, again, care management, case management infrastructure. To a degree, their data and analytics enterprises. We're already buying that. And so this really allows us through this construct to take that buy that we make, that care, that case management point, that piece that you just made of really pushing it forward and getting engaged with that individual who comes into this benefit. Is I wanted each and every one of you to see, to meet, and know that these folks have invested in this. They have devoted the last 5 months of their professional career at the state working to make and build this product. And I want you to see and understand their expertise. So, Dr. Peterson.
So I think to your point, yes, we would track patient satisfaction. So there are many ways that you can look at patient satisfaction. One of the most common ones is the HCAFs coming through healthcare systems. The MCOs do provide us some satisfaction numbers today. My experience has been in the area of patient engagement, which has been long for me since being in the VA and working with some of our veterans who have struggled to find adequate care. It doesn't really tell a full story. So some other ways that we have thought about is using a qualitative approach, which does more focus groups outreach from those individuals who may feel more disenfranchised from their care, or to the point of may have lost prime coverage for one reason or another. What we don't want to do, I think, is what some of you may be questioning, is to penalize individuals for not engaging in their care. And so moving someone back down to basic, they would remain in the health plan. We would continue to monitor that engagement and continue to work and support them through trying to engage them in care management. However, it is the patient's right to refuse that. And because some of them may, for many reasons, not want to participate, we can't require that. We can only incentivize it. And so while we'll continue to work with the patient and try to understand why it may not have been effective. I know I have a son with asthma, and I've gotten those calls at times from various health plans, and it doesn't always feel valuable to me. So sometimes I don't answer those calls in the middle of my workday. But those would be things that we could learn, and certainly will be an indicator at some point. We just may also have some depth to the quantitative.
So not all of this is, the cost is tied purely because we have the tiered package. Some of it is we're more informed, but we have better information around the risks and what we can put in place to mitigate the risks in other states. A lot of the cost is driven from the enrollment and eligibility piece, which is something we handle. The MCOs have we partner with the MCOs today on the program integrity side when we look at it from a provider perspective. This is more focused on member, like an SIU, Special Investigations Unit, member-focused type of activity. So it's a little different.
And then I had one more. Oh, go. Yeah, I just have one more question about the managed care entities, but if you want
to add something to that, sorry.
Yeah. Lean over. I was just going to say, so I think one of the KPIs that we've already suggested for a post-implementation metric is part of a typical value analysis for a program implementation, which would look at, Jeremy had mentioned the PMPM. So we would look at, does the PMPM change over time? Our anticipation is not in 1 year that we will see an adequate PMPM change to be statistically significant. However, what we would do is also look at metrics which are indicators of where we would see a longer-term shift in that cost offset in things around more costly acute care, such as hospitalizations after an emergency visit, meaning we probably didn't do proactive outreach after they had an emergency visit to stabilize them that landed them in the hospital. So in the first year, we will have to look at some additional metrics to look at, are we implementing the program and getting the value back to the taxpayer that's desired? And then longer term, we may see that actual cost of care in a PMPM capitation rate go down. That does take a little while.
Because it's my understanding that 73% of the population we're talking about is already employed. So are we talking then, when we're looking at job searching and those kind of things, is it to get them to an employment level where they will then not have to require on public services?
Potentially, I'll punt this to Mr. Thompson, but if they're already employed, they already qualify for Prime, but that does not mean that we won't be care managing them and helping them improve their situation, regardless if they even perceive themselves to be in a kind of an okay spot. They may still have aspirations. They may have a roadblock into getting a management position or something similar. So,
Okay. And then in terms of the managed care entities, my understanding is that that 2 of them have merged. So is that correct? So will we be going through an RFP during this process as well to look at an additional managed care entity to bring on?
So again, that's noted the press release that we had on that subject between the Centene WellCare. It's a Centene acquisition.
Okay.
It's proposed, and I think the important thing to remember is that that is in and of itself a process that's going to be working over time. I would also say that our expectation is that we have 3 plans, and one of the fundamental tenets of Heritage Health is that there be consumer choice in the marketplace, and we've articulated back that to our MCOs, and that has been supported coming back to us. Now, in terms of what this does to our reprocurement, because these contracts, as Deputy Director Brunson noted, do end at the end of 2021. So that does put us in a position where we will begin to work through the processes of reprocuring, and we'll begin those processes under Deputy Director Lashinsky's auspices. And I would ask Heather if she'd like to add anything to that. She's welcome to.
Senator Williams?
Thank you, Chairperson Howard, and you're sitting in the right spot. 2 quick questions, Dr. Van Patten. First of all, early in your testimony, and maybe I misheard you on the working requirement, are we talking 90 hours or 80 hours?
It's 80 hours.
80 hours a month, okay. Second question, we've learned a lot over the last 2.5 years about managed care, what has worked, what hasn't worked, those things, and appreciate everybody's work around that, and especially your meetings that you continue to have on that. When we talked, and when Senator Hilkeman talked about the dental coverages and those, are we going to use the current model of managed care that is working successfully, at least that's what we are hearing, for the dental coverage under this expanded population?
So we currently have a dental benefits manager, which is MCNA, and they are in place to accommodate the existing population. Our intent would be to look at where they are at this point in time, but then there's also, and I think this is just good business assessment, as you're integrating a new population in, the pre-existing 3 healthcare MCOs could also add that benefit as well to their portfolio. So we're going to look at both, but right now we do have an infrastructure that's in place with MCNA. I've had very good conversations with Dr. Hunke and Dr. Wheating with that team, and I have shared with them our desire to show how these 2 systems connect back, and he seems to be very enthusiastic in helping us find those paths. So
thank you
again,
for that analysis. In that analysis, I hope you will be taking some time to ask the dental providers and the other providers about their experience ratings in the Heritage Health 3 MCO package that's dealing, and then those on the dental side.
Absolutely, we will.
It is certainly our input from the briefings that Senator Howard has organized for us that there's a major difference in that satisfaction level.
Yeah, absolutely.
Thank you.
Happy to.
Senator Dorn?
Thank you, Chairman Howard. And I think my question's maybe for Jeremy, and I see he keeps moving farther away.
It's always the money man.
But maybe you can, I don't know who, part of what was in Jeremy's conversation early on, you talked about the programs 348 and 347, and some of those that now will be affected by the first year not having the plan implemented. And I don't remember all of the numbers, but I remember behavioral health, they had a negative drawdown on there, but they also had an amount to cover that was going in there. How is that going to be handled, or how will they be expected to have their budget affected the first year then?
Let me answer let me give a preface and then let Deputy Director Brunson fill in on the back end. Heritage Health in its package construct today is both the physical health, behavioral health, and drug benefit is all comprehensively managed. So many of the behavioral health providers are already in the Heritage Health program, and we already manage that part of the health benefit array as it exists today. And I think, and I'll let him elaborate, but I think part of what the challenge for us is knowing exactly how many of those beneficiaries that would currently be under existing behavioral health service array in the Department of Behavioral Health are going to come over as a member of the new Heritage Health adult program. What I will also say is I think, and I hope it's been showcased here today as what we've been working towards building with this adult program and the way we manage it, is that we're trying to leverage the full service array of government benefits and really connect the dots for the beneficiary and pull things together for them. And I have been deeply engaged in conversations with with Director Dawson in behavioral health, and she and her team now regularly sit in those those every other week meetings with our 3 MCOs. So we're working again to deeply integrate those service points together and moving forward, getting back to the auditing, quantification, and surveillance piece. One of the things we're going to be looking at is utilization rates within the behavioral health space. And there's still challenges with that. Now, a best example I can give you, Senator Dorn, on that front is take, for example, a woman who's just delivered. She goes in to see the OBGYN after delivery, and she receives a diagnosis that says she's maybe suffering from postpartum depression. So she gets a script. Well, you may not ever get the diagnosis because the way it's coded in the encounter data it's just a follow-up visit. The only way you know that there's been an event that may tie out to that is you've got an RX that coincides. So again, that's where our data and analytics becomes really powerful, and why we need to work to build that infrastructure that Dr. Peterson's working to do so that we can make those more comprehensive studies and threads. But I'll turn it over.
Well, thank you for that part of the explanation, but it still,
Go ahead.
they said they're going to have a $1.8 million, I know behavioral health, reduction in their current, or in the 20 fiscal year because of income that they were expecting or was budgeted for from expanded Medicaid.
Yeah.
That's not happening now the first year. How is that being handled?
So Senator, thank you. What we've recommended is that we not reduce their appropriation by the amount that we thought those services would transfer into the Medicaid expansion population. So we recommend not reducing their appropriation in state fiscal year 20 to have those dollars for those regions, because they will be providing the services, because we will not have expansion in place. And we've prorated that based on the numbers that are used in the ramp up for this following state fiscal year.
And in the second fiscal year, that should come back into play. I mean, it should come back into the equation.
Yes,
part of the
it certainly will. Yeah.
Thank you.
Other questions? Senator Clements?
Thank you, Chair Howard. I had a question just about capacity of family physicians to take on an increased number of people and requiring a family physician visit. Are there going to be physicians who will accept more patients that are on the Medicaid provider rates?
Currently, we allow family practice, general practice, internal medicine, pediatricians, and OBGYNs to be primary care providers. We also allow nurse practitioners that have that specialty to be primary care providers, and physician assistants. Additionally, we also allow the practitioners within our federally qualified health centers and our rural health centers to be primary care providers. So we have a very large pool in which to draw upon. With that being said, we do know that the managed care plans will need to look at their network, their network provider of network providers, there we go. Especially around the internal medicine, because we know that this population is more, they're not the moms and the kids, and so we need to look to see if we have adequate networks or if we do need to build that capacity, and that is also part of the time frame, is allowing our health plans to build that capacity so that we do have enough primary care providers for the new population coming on.
And do you have an estimate of what percentage of the new population already have a primary care provider?
I think, Senator, for the population that we currently serve, we can certainly pull those numbers to begin to look. But beyond that, it's a very hard thing to estimate.
Right, yeah, you haven't been in touch with that population yet.
And I think that, again, is an important upfront piece of helping them find that point, but then also giving the MCOs or the health plans time to assess network adequacy, to look at who's in, and to accommodate that. And I think just reiterating the point that Deputy Director Lashinsky made, this is an adult population. So we know from experiences from other states is that they're going to come in with some higher care needs, and that's going to require higher acuity or level of care that internal medicine docs are going to be better suited to taking care of in an adult population. So we'll need to allow times for those 3 MCOs to build out their provider networks to accommodate that.
Thank you.
Senator Arch?
Thank you. I've got a follow-up question to Senator Clements on networks. Do you, and I don't want to get too far down into the weeds here, but do you anticipate that for the MCOs, they will have a Medicaid expansion network and what I would call a regular Medicaid network? Is if you're in, you're in. If you're out, you're out.
I think it's building upon. So what I would tell you today is you have to start with what you currently have and who you're currently serving, and it's 73% of our population is women and children, as was indicated. So that sort of dictates what your care infrastructure is going to be. This is adult. And so adults with chronic disease states and things that may not traditionally have been emblematic in the population that we serve, as well as higher level specialty that we're probably going to have to, again, assess and build that network. And again, that goes to engaging these folks very early on, getting them in to see primary care providers to make sure that as we're pushing them up, as they seek out greater and more complex care exchanges and specialties, that we've got that network. It's an ongoing process of evaluation, and it's actually one of our existing metrics on our scorecard that we shared is assessing network adequacy.
Understanding that the new population will bring in adults, I mean, there are certainly adult covered under Medicaid now, but this would be a major expansion.
Springboard off of.
I guess back to that question, do you anticipate that this is going to be 2 networks, 2 provider networks, 1 provider network?
I think
and it will be a provider network that will include pediatricians and OB, but a desire to expand the internal medicine specialty.
I would see it in that space, yes.
Okay.
It's you're an MCO with a provider network. It's just building off of what you have or adding to.
All right, thank you.
Yes, sir.
And we've only got about 5 minutes left. So I wanted to ask you, I know other states have applied for the 6-month renewal in their 1115 waivers. Have any of those been approved?
Not to my knowledge. I don't know what's happened in that space, but I'll let Deputy Director Thompson answer.
I can't name them right now, but there have been states that have 6-month renewals approved.
So you'll
We can
give us
send
a
that to you.
follow-up?
Yes.
Because I couldn't find any when I was looking, and it felt strange that we were applying for something that hadn't been approved in other states. And then I know that there are some statutory changes that you're going to need as you process through the 1115 waiver, particularly the EPSDT disallowance. That's already in statute, and so if you do that for a different population, you'll need us to change that statute. How does that impact your timeline?
That's something that we would have to work through. I don't think that will impact the timeline because that's something that's just requested from CMS.
Oh, perfect. And then tomorrow, you mentioned in an email on 6:45 that tomorrow you're going to tell us a little bit more about your MMIS sunset plan, or the plan for your sunset for the claims broker system. Do you want to give us a quick preview?
I think that we can have
Everybody's
Dr.
all-
Peterson.
Dr. Peterson?
No, I don't.
It gets to that, no one wants to take that one, so that was easy to point the finger. So you are correct, we did have a systems integration interoperability meeting scheduled for tomorrow. In order to best prepare for the briefing today, we rescheduled that as it was a systems meeting. One of the things that I'd like to share, however, is the MMIS sunset strategy, and to align it with the governor's kind of IT vision of leveraging the value of interoperability and the 90/10 funding through CMS. We're partnering at a very high level with all the divisions at DHHS. So it would be disingenuous for me to kind of lay out a plan. We do have a roadmap that we are planning to share with the division directors, as well as the OCIO, as well as other important stakeholders. However, they have not had a chance to view the suggested interoperability plan for the state of Nebraska. What I can say today is MMIS and NFocus have been a significant part of the state's infrastructure. To completely come off that, and when we say sunset, not use it for any business purposes today, is not even at the end of the roadmap that you will soon be presented with. And the reason for that is it wouldn't make a lot of sense for us to do that without doing a significant value analysis that would look at where is that floor of cost per claim and the ability to just maintain ongoing operations. We will move to a modular approach, which is what's being pushed by CMS, and the only thing being funded at that 90/10 funding. But even with that plan being laid out, in order to successfully implement, much like I stated with Medicaid expansion, we need to ensure that we have the time and resources to do each module properly so that we don't have a failed implementation. So I don't really foresee, at least in my illustrious state career, that there will be a complete sunset of MMIS or NFocus without some really thoughtful approach to we've reached that floor of the value in those systems. But we will continue to build modularity so that we have options to do things like claims broker or fiscal agent or other things that are supported by NFocus and MMIS. So that will be in a roadmap that the other directors in the OCIO's office have yet to vet the draft that we're proposing based on just best practices and the 7 standards and conditions that are required by CMS.
Thank you. All right, I see we're at time. Senator Stinner, do you have any closing thoughts for us?
Thank you. Thank you for bringing your people. This was informative. It's nice to see how this all fits together. So thank you very much, Director. You got some great people here. It's a heck of a challenge. So it was very informative, certainly for me, and certainly for, I think, everybody here. So thank you.
Yes, thank you for your time today.
You're welcome.
All right.